All right, next we have joining us by video, Shawn Moshrefi, speaking on special considerations for arm lifts, thigh lifts, and abdominoplasty in lipedema patients to optimize outcomes. And Shawn's in practice in Beverly Hills.
Hi, everyone. My name is Dr. Shawn Moshrefi, and I'm a board-certified plastic surgeon at the Roxbury Institute in ALT. I'm incredibly excited to be speaking with you at FDRS 2024. So let me go ahead and hop into my talk right now about body contouring. I have nothing to disclose. As an overview, we're going to talk about what's important in body contouring for lipedema, what are the pitfalls that you can encounter, the important anatomy, just as a quick highlight, and of course, why is my technique different and how are the results superior? Namely, is lymphatic sparing, nerve sparing, and venous sparing when it comes to brachioplasties, thigh lifts, and even tummy tucks. So as far as body contouring and lipedema goes, oftentimes you'll start with debulking and release using tumescent liposuction first. And that's where my colleagues, Dr. Amron and Dr. Arya Vizirnia, come in and do the liposuction at the beginning. And sometimes patients will opt for thermal heating devices. However, unfortunately, tightening with this is often inadequate due to the degree of laxity that lipedema has imparted as part of the process. And so that's where I come into things as a tailor of the body, where basically I will pinch and pull and determine what is the degree of soft tissue that can be safely removed and skin that can be safely removed to get you the nicest contouring results while concurrently doing that at the same time as the debulking. So same stage surgery with the debulking liposuction to allow for the best results with less surgical stages so that there is less time under anesthesia and less number of trips to the operating room. Of course, there are some pitfalls, which of course is that body contouring in lipedema is not the same as in non-lipedema patients. Let me say that again. Body contouring in lipedema patients is not the same as in non-lipedema patients. This is not a weight-related phenomenon. There are wound healing concerns in this patient population, such as collagen disorders, Ehlers-Danlos, etc. And of course, this really takes a multidisciplinary approach to improve upon the results and get the patients the safest and best results they deserve. So lipedema debulking also involves a large volume infiltration of tumescent anesthesia. And since this is done first, the body contouring that happens afterwards, the surgeon heading in is going to have a lot of distorted anatomy to deal with because everything's going to be swollen and puffed up from all the fluid. And so if you have a surgeon who's inexperienced or doesn't really understand the technique that I utilize, you could fall into the trap of having ill-placed scars, irregularities, and of course, one of the most dreaded complications, being unable to close the wound. In other words, the surgeon has overestimated how much soft tissue is going to be removed preoperatively, and once there, subsequently now, they're in trouble because now they have removed more tissue than what can be handled to close in one setting. And that's something, knock on wood, I've never encountered and hope nobody ever does. So brief hit on the relevant anatomy. The most commonly injured nerve in brachioplasties is the medial antebrachial cutaneous nerve depicted here running from the arm into the forearm. Knock on wood, with this technique for the last 8 or 9 years I've been using, I've not had a single such complication. The veins are not depicted here, but also the cephalic vein and basilic vein can oftentimes be injured if the surgeon is not careful, and those are, again, important to preserve. Moving down to the thighs, that is incredibly important to avoid injury because the great saphenous vein is a really important part of venous outflow and also will significantly delay healing and increase the amount of swelling the patient encounters. Also, infrapatellar branch of the saphenous nerve and other cutaneous branches to the overlying skin of the inner thigh can be injured if, again, the surgeon is not careful. And again, important to utilize a venous sparing, nerve sparing, and lymphatic sparing technique. So how do I do it? Markings. They're almost everything. I spend tons of time in marking. No one can rush me. That's where we really, really drive everything home. No general anesthesia. We do this either awake or under twilight sedation when the patient is very comfortable. Debulking is then done by my colleagues, Dr. Amron and Dr. Vizirnia. And then subsequently, I will then measure twice and cut once. You'll hear me say this in the operating room a lot because I tailor tack everything, temporarily put it together to make sure the scar lines up where I want it. Everything is looking good and it's not too tight. And then subsequently, we'll go ahead and cut and remove all the excess tissue. Again, preserving the nerves, lymphatics, and veins, closing at about 3 to 4 layers. No drains needed, but again, diligent compression afterwards. And I think a lot of excellence, people talk about excellence in surgery, it really comes from doing the same thing on a consistent basis at a high level with easily reproduced. People talk about excellence in surgery. Well, excellence in surgery really comes from a few things. One is being able to do great things on a reproducible basis, and repeatable success is really what equates to excellence, in my opinion. And so that's what we're trying to achieve here. And of course, I recall one of my old bosses saying, just don't mess it up. Well, what does that involve? Meticulous attention to scar placement, staying in the correct plane above the muscle fascia to prevent muscle and nerve injury, and providing the least amount of trauma to the involved tissues so that you can preserve lymphatics as well as veins. No bleeding, as many of my colleagues will comment, or my coworkers in the operating room will comment that I hardly use the cautery and electrocautery. And of course, then we'll sew like the wind to get you out of the operating room in a safe fashion and enjoying your results. Some quick hit before and afters. You can see circumferential arm liposuction with an extended brachioplasty here, and in the field goal position here from the front. You can see the scar. Well, of course, her arms are up, but at her side or at conversation distance are not visible, and they're very well hidden. And again, here, as you always hear me talk about in my videos, no scar visibility from behind as well. So you can go a sleeveless or short sleeve without the concern of the scars being shown or visible. Again, a different patient, again, older patient, much more lax arms, heavier, but again, what a huge transformation where the arms are no longer weighing things down. Example of a thigh lift, you can see a short scar thigh lift with the scars tucked very tightly up above, and a very nice debulking as well. And that's a wrap for me. Again, my name is Dr. Shawn Moshrefi. I'm at ALT and the Roxbury Institute. You can check out my Instagram at Dr. Shawn Moshrefi if you want to see more before and afters or connect with me directly. Hope you're doing amazing and enjoy the rest of the conference. Take care.